economic access. And when we see about urban and rural divide, we also see an economic divide there.
Mhm.
I think their government of Rajasthan has been much more progressive than many states. But having said that, I would still say that the states could do much more in terms of bringing in new technologies. Because one aspect, as much controversial as it may seem, we always talk about cost effectiveness, but effectiveness part gets missed out sooner than later, right? And the focus remains on cost. One reason for that is because we don't publish outcomes and data. So I think that's one important aspect which I would encourage the state of Rajasthan to look into as a progressive state compared to others. It's surprising, ma'am, that today if I have to order food, I have more data on Zomato and Swiggy about ratings of restaurants than if I have to take a family member for good healthcare. Where should I go? So I think that's one access that we need to bridge, especially for the rural areas. Second aspect is the technology could be the same. We as companies provide the same technology to the urban and the rural areas. But you need a physician at the end of the chain to take those technology to the patients. So building around academic programs and medical education programs where internship in rural areas is a must, and how we could partner. Obviously, we also want to bring something to the table to ensure that the competency and capacity divide in terms of physicians is not dictated by the facilities that are offered in a city.
Yeah. Mhm.
So I think that's where more innovative training and education activities need to come in place. Like Meenakshi mentioned, I was also in SMS today morning, and one of the big discussions was about the investments the government of Rajasthan is making in setting up cath labs in 22 districts. Now, those cath labs need skilled operators, right? So, how do we also use innovation not only in the technology, but training those people using a hub and spoke model so that the people in the rural areas also get the same access? And lastly, is a trust deficit. Somehow, people in rural areas, even if you provide the facility, believe that better care is available, in the city. And the biggest cost these families incur sometimes is a displacement of families
Mhm.
coming from their homes, leaving their livelihood, and coming for treatment to bigger cities. So, if again, going back to the suggestion I was making, if we could publish data, if we could publish outcomes, and the healthcare you get is not decided or by whom but every door you walk into the state for healthcare, you are assured of the same quality. I know that's like a North Star. That's a goal that we need to take small steps towards, but we would be happy to partner in that. And that would also be my suggestion to the esteemed government officials on the stage.
Thanks, Dr. Mandeep. I think that was really nice. And you talked about this urban-rural divide, but at the same time, not just social, but economic. You also said about that it has something to do with the academia, like institutions where I belong to AIMS or SMS Jaipur or state medical schools, where the kind of training should be like this, which ensures the kind of quality of services which we give both to the urban and rural, we equal and have that acceptability both at the urban and the rural areas. So thank you so much. Now we next go to the next panelist, Dr. Puneet Puri, who is associate professor in Virginia Commonwealth University, and he is known for developing models of care and work with the largest integrated healthcare system in the United States. I was going through the work you are doing. You are doing work on the NAFLD or non-alcoholic fatty liver disease. So we have been talking about all those questions related to rural healthcare and population based versus patient centric. Let's hear from you, Dr. Puri. In resource poor settings, how feasible it is to have a resource adaptive population health management strategies, particularly in the area of NCDs.
Thank you, Dr. Pankaj, for that kind introduction. And I also thank the organizers for this opportunity. Being a Rajasthani, like I was born and raised here, and also went to school at medical college, at Savai Mansingh Medical College, and now I practice medicine in US. It gives me a good opportunity to bring back some of my experiences and how this could be leveraged. And I think I practice most of my medicine in a very resource-rich environment. But being at the Virginia, at the Veterans Affairs Hospital system, there is a lot more because it is the largest integrated health system that takes into account the total population, close to 10 million veterans, which is about 1 crore. So I see the initiatives from the government are in the right direction to introduce insurance, government schemes that can include so many more. I just heard the Honorable Minister mention that close to 60% people are using the government schemes, which is a great initiative. And how can we leverage this in a resource deprived setting? And the very first question is, what is the problem? And to get to the problem, we need to have some kind of understanding of the data. I cannot equate that in Churu, I can have a similar problem, different definition of like diabetes, high blood pressure, cancer risk. Maybe it's different in Junjunu, maybe in Pali, or even in the Tonk or other parts. There can be also socioeconomic disparity that drives certain diseases are more prevalent and more communicable to non-communicable. So we are looking into the non-communicable disease model. How, in a resource constraint setting, we do is first identifying the burden of the problem. If we are able to better quantify the burden of the problem, that can identify which areas need resources. And as we talked about, that lot of big hospitals are already there in the state. Are there willing or is there a willingness to open smaller units of a higher quality that reaches out to the patients rather than patients reach out to you? Now, if the government thinks that, they can identify satellite hospitals. As an example from where we practice, there are people, veterans get full benefit if they come to the veterans hospital. So they may be living 400, 500 kilometers far. How do they access care? There are two common ways. We have established satellite hospitals that meet the criteria of good quality care, which is midway to them so that they can access that within an hour's distance. And number two, we have robust telemedicine platforms. And that can exist in form of like a video call to the patient, or that can exist in form of providing a virtual visit. That can also extend into using facilities that have devices set up at home, as Minakshi was mentioning about reaching out to them for cancer screening. So I think if we identify the problem, we define where to allocate resources, we have made half of the battle successful in that regard.
Great. So thank you so much, Dr. Puri. I think you very rightly mentioned. Let's hear from all of us what are the burden of problem. And you said very right thing that willingness of these bigger hospitals to establish their units, and that is something which is a very unique idea. And you said about all those remote monitoring of patients or telemedicine. These are some of the ideas which are important to ensure accessibility to all. From this only, let us go to our next panelist, Richa Devgupta, who's the Chief of Strategy and Operation of Fortis Healthcare. Madam, you represent the biggest Fortis private care chain. And just now, Puneet said, willingness of bigger hospitals to come up to help the rural sector of India. So over to you, madam. So what's your idea on that? How, as per you, what you feel that how can the collaboration between private hospitals and government health programs be improved? What is the challenge?
Thank you, Dr. Pankaj. I think it'll be only fair. First, I must compliment Madam Gayatri. The way she highlighted all the focus area the state is focusing on in terms of health. I was very pleased to hear that how they've actually exceeded what central government has decided in terms of coverage for the people above 70 years. That's really encouraging. It says that there is a government which cares for their people, and that too also the senior citizen, the geriatric population. Thank you. Coming on to how private and public people can organization can collaborate. See, it is I think very important when we talk about healthcare, particularly 60-70% of the tertiary and quaternary care is being provided by the private chains. So it's on responsibility on us, the private player, that we collaborate with the government, and it is possible, very much possible, and we have seen that happening during COVID time. That was the best example that exists for anyone to see that how public sector and private sector actually can join together and can overcome something as large as scary as COVID, right? So that's one part of it. But getting into the nuances of how do we encourage that, how do more private players come into participate in that. First and foremost, I would touch upon a touchy area, which is trust deficit, right? The moment private player comes in, the government comes in play, I do feel there is a bit of a trust deficit that exists. And for that, the clear solution is communication, regular communication, deciding parameters that how the performance of a public private partnership is going to get evaluated. What are the, don't look at the end outcome and then decide whether it failed or it succeeded. Set up the benchmarks that how you're going to measure that. That's one part of it. Second thing is that um, private player is there, somebody has made the investment, so they have to kind of take out some amount which they can reinvest, and hence there's funding which is not coming from the government body. Somebody private has invested, so they would like to keep the ball rolling. For that, incentivizing or kind of giving some kind of subsidies to the private player, that will go a long way. That's there. For all the sector which has got an industry status, unfortunately, healthcare delivery is still struggling for that. So that would be another way of doing it. And I think, when we talk about programs like vaccination, when we talk about programs like disease management, that can be dealt with very, very successfully by involving the private players, right? Again, I would talk about the COVID vaccination. Anywhere where in the world did we do that large scale of vaccination? Not really. We could succeed it because we pulled in all the possible resources, such was the scenario. So that's one. And disease management, when we talk about TB program, that's something which Grace reminded me that that's something that India has done so beautifully. So that's the second thing. Third thing I would say is the training people together. Most of the time we struggle with trained manpower. And whenever the nursing opening comes up in government sector, all the nurses want to leave the private sector and probably join the government sector. So I think to have a same standard of quality, if we combine the training programs between private and public, that's something which again can have a huge difference, can make a huge difference. So those are the few things that I would say how public and private can actually collaborate and work together. Thank
Thank
you.
you. Thank you so much, Richa. I think you talked about, again, first of all, you talked about trust. I think that was an important part. And both these sectors, the private as well as public, they should have that sense of trust on each other. Incentivization, though, is an area where Madam Secretary and Minister Sir would be the better person to say about the incentivization or what kind of subsidies these private sectors can get from the public hospital. And last but not the least, you said about standard of quality, which is there. As you said, that once there is an opening, you are going to lose your human resource to the government hospitals, and then it's a kind of a, again, a kind of difficulty for the private players. So now it's the time to go to our next panelist, and Grace is smiling. And Grace Achungura, whom I know for a few years, India Technical Officer Health Financing for UHC, HCF, World Health Organization. Grace, you have been working in different countries on the health financing part. Let's hear from you. How do you have in your view the steps which government of India is taking to have a transition from volume based care to value based care? And that's an important concept which every one of us would like to hear from WHO. We know you are the advisors to many countries, but something on transition from volume based care to value based care.
Thank you very much, Dr. Pankaj. Um, Honorable Minister and Madam Principal Secretary, thank you for having WHO on the panel, and I bring compliments from the country representative. The issue of volume-based care versus value-based care. So volume-based care is really about how many services you can put out without really being mindful about the quality of care or the outcomes of care, while value-based care is really looking to maximize value, both from the clinical perspective in terms of health gain, but also quality of, and taking into account the patient's perspective. And then while minimizing the costs in achieving that. We, as WHO, have done a global review looking at what is needed to transition and how India is faring in that regard. So in terms of what is needed, picking up from what Dr. Puneet Puri was speaking about, patient-centered care is at the heart of value-based care. It is about what outcomes they prioritize, and these have to be aligned with what clinically is objectively valuable. And secondly, it's about ensuring that the patient is not having to hop from different places to seek that care. So really around organizing care around the patient. And the way many countries have been doing that, Dr. Puneet talked about the Veteran Health Administration in the US, is seeking to integrate care. You can do that by using services like telemedicine in places where you have geospatial challenges in achieving that integration, but where you are able to collocate services, mental health services, nutrition services, physical health services, together with behavioral care and other biomedical services within one, in order to be able to provide that patient that care that's important. Others have gone further, and I believe that is the model that VHA is using in the US, by collaborative care, where you have integrated practice units. These are interdisciplinary teams coming together, coalescing around a patient on a particular condition. Now, the issue is, how do you actualize that? So physically, the issues around collocation and telemedicine, but other instruments exist within our ambit to do that. So from a the decision-making perspective, one of the things you need is data. You need data and good information systems that will give you information on the costs and outcomes. So you need cost surveillance systems built into your information systems, systems that are giving you data on quality of care. So you have to have quality of care indicators like the UK does with the quality outcomes framework, which has a long history of implementation, and there's a lot that countries can learn from that. You also need to have data that can give you an understanding of where inefficiencies are happening in cases of variation in care. The other thing that you need then is how you finance this apparatus. And some of the things that we see happening in like the UK, in the US, in France, is you pay for coordination. So you have one entity that is coordinating, say, a number of providers, but you're giving them an incentive to cover those costs of coordination, or a certain unit within a facility. Moreover, you can also pay using advanced payment models that are bundling services together for a particular episode. So you're covering pre-hospitalization, hospitalization, and post-hospitalization, any counseling that is needed around that, home care visits, all of them bundled in one episode. That tends to be more efficient. And experiments that have been done through the Center for Medical Innovations with Medicaid USA has shown some gains in terms of cost savings. There are governance changes that need to be made around that in terms of clinical governance that allows the team to be reorganized in the facility, SOPs and the like. Like I said, WHO has made a review on this, where we bring together learnings and this can be shared. I think India is on a good track with the changes we are seeing, especially at the PHC level. We are seeing some important movement towards patient-centeredness and the incorporation of telemedicine, the use of performance-linked payments to incentivize team effort towards providing care and the like. So I think there is some change, but the report we have I've talked about also highlights some areas for improvement. Thank you.
Thank you so much. I think you talked about that patient-centric care and the quality indicators, which you mentioned that these are the part of WHO framework, is something which is very important. And just to share with you, and I think we have gone through that one paper which is published recently with your team. And just a quick comment on that, because we are moving toward the last part, and we request all panelists we'll come again with one single question with a very short comment or answer, so that we invite our chief guest of the ceremony, Minister Sir, to have his views. But before that, a very quick one comment we'll take from each one of you. So we'll start with Grace again, though you were the last. So in the second round, you'll get the first chance to speak. speak, and that is on Pradhan Mantri Jan Arogya Yojana. We call it as PMJ, and for you, as you don't speak Hindi, but you understand that this PMJ is about where we are unifying the defragmented these schemes which are there with multiple names being run by multiple departments. So your view on that, and how do you rate country on that of PMJ?
Mm. Okay, so fragmentation, when we're looking at the health financing landscape, but also service delivery landscape in the health sector, fragmentation is not good. It exacerbates inequities. It exacerbates challenges with quality of care. So in as much as we are able to defragment the system, it's an important thing in improving financial protection, efficiency, and the like. In that paper, we were looking at how the information communication system that PMJ uses has furthered this defragmentation agenda. And I think India is very unique as a country, and many countries can learn from that, in that it has provided, that system has provided scope for where defragmenting completely was impossible, at least harmonizing information across different schemes so that at the level of, say, the principal secretary, you're able to see what is happening across the population, which is a good thing to help you in terms of minimizing people being left behind. In some states, like in Kerala, they have managed to partially at least merge some schemes together using the information system. What that has meant then is that you have a larger group of people having that same benefit package, going to the same hospitals.
Yeah.
That now results in improved equity. So things like that is what, and then it has also facilitated better portability of services. States like Bihar that may have some challenges in providing some high-end care are able to send their patients to other states that are able to provide better care, and there's the ability to pay that what is owed to that state seamlessly is one of the benefits we are seeing.
Thank you so much. You very rightly said the partial or the full harmonization of these policies and these schemes is actually benefiting the patient at large, whether he or she belongs to Rajasthan or any other state of the country. Thank you so much. A quick question from Mandeep. Again, a very quick comment. What steps medtech companies need to take to ensure health equity? Again, health equity. Let's talk on that.
So I briefly alluded to that, in terms of the medtech companies could do a lot in terms of training and education, in terms of building capacity and capability within the system. So the technology is one thing, but the outcomes of a technology, they lie in the hands of a physician. So I think one is the work that the medtech companies could do, really. The second would be in terms of, Meenakshi alluded it more from the pharma side, but also for the medtech companies to bring in their latest technologies. And we as a company are proud to be able to do so that the Indian patient gets the same quality of care that the advanced countries are getting. So timeliness to innovation and democratizing access to training and education.
Thank you. Democratizing that, something which is very important, and I think Indian government is working on that, and state government equally. Meenakshi, over to you. PMBJP scheme, we call them as Jan Aushadhi Kendra. So they are bringing down the cost. Your view on that? How you are actually, as a pharma sector or as a pharma industry, is looking at the Jan Aushadhi Kendras?
No, I think from a concept perspective, it's great, and I think that's the whole idea that it should be accessible to all. I think the big conversation every time we are in front of the regulators is all about the quality. That as long as there is each state, because quality and manufacturing becomes a state issue, as long as the quality metrics, whether it's GMP or WHO GMP, whatever it is, as long as that is maintained, then to be able to get medicines at low cost is it's like it's fantastic. But I think that is the main thing that we are also all trying to drive, and the challenge back to us is why don't the bigger companies adopt the smaller companies to drive up the quality. So everyone is trying to do that, but I think that is the main issue, that at least whenever we are in front of regulators presenting our dossiers, the main discussion is what can we do to drive quality of manufacturing.
Thank you so much. And I think quality is always an issue, but in Jan Aushadhi Kendra, the quality of the generic medicine is always being watched very carefully when it comes to a country like ours. Over to Vibhav. Let's hear from you. We have been talking about health technology assessment. Now it's a new buzzword in India, but we know that it's very important for our country. We don't have nice guidelines currently, but we do have HTIN. And when we have a limited kitty, we know where to invest. We know what are the alternatives which are available to us. So your view on the country's initiative of starting health technology assessment units and health economics.
Sure, thank you. I think Rajasthan covering 25 lakh rupees for individual family, almost 30,000 USD, has left behind not just many states in the country, but many countries across the globe in terms of the coverage, honestly, right? The question comes is how do we utilize this $30,000 per family in the most optimal way? And I think that's where health economics modeling and HTA come very, very handy in my mind. And therefore, my recommendation to Honorable Minister, Honorable Secretary on the dais would be, how do we deploy, how would they help in the masses, how do we analyze that? How do we do HTA from those newer technologies that Mandi was talking about and include them into the Ma Yojana by doing the health economics modeling as well? I think it'll be a fantastic combination of these two things to look forward into the Ma Yojana. Thank you so much.
That's great. It was crisp, but I think very useful. Health economics, as ma'am says, that it's about effectiveness. Health, it's about cost effectiveness, the efficiency, but at the same time, health and cost effectiveness. Richa, over to you. We know that you've been the private sector was very helpful at the time of COVID-19, and there's no denying a fact. No one can doubt. I belong to a central government-run organization, AIMS, but we know that you lend a very helping hand to each one of us. But how can healthcare systems be made more resilient to pandemics and other public health emergencies from the side of a private player?
Sure. I think we have learned a lot, and this learning was very expensive, though. So I would quickly say that first and foremost, build an infrastructure which is robust. What I mean by that is that infrastructure which is expandable, right? And second thing is that they should be quick to respond to the health emergencies, right? That's one part. Second part is including community in health education. That's a must. Because you would have realized it that initial days when people had difficulty putting a mask, it became a habit to the point that 2022 when we actually started discarding masks, you started thinking I'm leaving something behind. Earlier it was mobile which people used to carry. After that it became mask, right?
Yeah.
So people adapt very, very fast. We undermine their don't undermine the this thing of common man. There's a dialogue of Shah Rukh Khan, so that's what it is. And next, I would say is that research and development funding, that's a must, and especially for the infectious disease. Somewhere seeing that skewed graph that, now lifestyle-related diseases are taking the prime, we have forgotten that infectious disease actually can create havoc. So research and development funding has to be much more than what it is now. So these will be the few things that I would say.
Yeah, thank you so much. Research and development. We all have our Minister Sir here and Secretary Madam and Secretary Sir. So I think R&D is very important part. But let's go to the last in the queue, Puneet. So over to you. We have been talking about in the panel about data, and data. We have been also been talking about Secretary Madam talks about the digital health mission. So when data is being generating, it's more about the safety, the protocols. Let's hear from your perspective on digital health as well as data security and policy, because you belong to a good country who boasts of having a very stringent data management system.
I think you just hit the nail on the head. Data integrity and data quality are key to preparedness. Just as you said, as to if we had robust databases, we would be in better position to kind of prepare and handle any eventuality that can come. I can just simply say that today, if I go and look in my center, how many diabetes patients did I see in last 1 year? I will, at a click of a button, know. If I want to find out how many have A1C or hemoglobin A1C greater than 9, it will tell me that 30% did not. I will find like which patients have been prescribed what medications. So we have to really think tank first, because not every system will work in a similar fashion. Just as the principle of like Steve Jobs, he would divide the pie into what are my like areas that I want to target. So I have a health system at a rural level with socioeconomic background, with some mid tier, so high tier, where we can integrate. And if a patient of my hospital has been seen in Hawaii, I still can see his records. If he is seen in Philippines, but a veteran, I still can see his records. So that kind of interoperability and accessibility to records are very important. So I feel that is a very important measure, and I'll be very happy to be integrated throughout this process wherever I can help. Lastly, to the quality, like no matter how senior you are in US, you have to go through your recertification exam. You have to meet your educational and qualification. Every 3 months, I have to certify a CPR, like if any patient has a code, I am ready to kind of provide the first, like what we call as advanced care skills, right? So these are important measures. We need to bring those practices in standardized fashion so that it percolates just not at top tier institutes, but also at a lower tier level. There should be standard of practice protocols. Like if a patient goes to a very simple, like a community health center, the doctor over there still knows, like, okay, if this patient comes this, these are my standard guidelines. I need to do this. So they are held accountable if they miss that. So there are some commitments, just not by the government, but also by the professional bodies that should bring education, quality of care, and accountability and partner what we can do to improve.
Thank you so much. I think you are the last in the order, but I think you summarize it very well. You said about interoperability and accessibility of health records. They are very important. If I'm at Jodhpur and if I want to consult somebody in Jaipur SMS, my records should be transferable. I need not to carry my records to SMS. And you said that interoperability and accessibility with a kind of a safety security measures on the data is very important. You also talk about a quality of education. Recertification is a difficult task, I know. I've been the part of this medical education for past 30 years, but I know that's a difficult part. But yes, for 3 months, as you said, recertification of skills is something which is needed. But yes, not 6, but I'll say at least twice a year, this once in 2 years or 5 years, a kind of a recertification of these skills can also be adopted. So thank you so much. Thanks to all the panelists who are with us today for these discussions. The time is short. We are closing it down, but we are coming to the open house to take questions. We have our pharma sector sitting over here. We have our medtech sector sitting over here, and also the part of academia and WHO, the part of team. So 1, 2, 3 quick comments or questions from the audience.
माननीय गजेंद्र सिंह जी, माननीय मंत्री जी और सम्मानित मंच का मैं अभिनंदन करते हुए मैं एक हम्बल रिक्वेस्ट करना चाहूंगा, क्योंकि आज का सत्र है वो हेल्थ केयर में इनोवेशन और ट्रांसफॉर्मेशन के संबंध में है। मेरी बच्ची कौशल रोहितवाल ने एक 3D इनोवेशन प्राइवेट लिमिटेड नाम से किया है, एमओयू भी किया है, और उसने 3D प्रिंटिंग में एक टेक्नोलॉजी इनोवेशन, जो एसएमएस के हॉस्पिटल से डॉक्टर्स होंगे तो देखते होंगे, वो कोई क्रिटिकल ऑपरेशन का, कोई जैसे एक्सीडेंट का इमेज भेजते हैं और वो 3D प्रिंट पे उस इमेज को डेवलप करके वापस देते हैं। मैं मिला हूं, मिस्टर सिन्हा थे पहले न्यूरोसर्जन हेड ऑफ डिपार्टमेंट, उन्होंने कहा कि ऐसी टेक्नोलॉजी भारत के हर अस्पताल में होनी चाहिए, हॉस्पिटल में होनी चाहिए। गजेंद्र सिंह जी उनका ये भी था। अच्छा, उन्होंने कहा कि जो आते हैं वो जो समर्थवान है, जो समझते हैं, वो लोग तो इस चीज को टेक्नोलॉजी को अडॉप्ट करके डॉक्टर से लेके पेमेंट करवा करके और वो 3D प्रिंट जो टेक्नोलॉजी से करवा के उसके प्रिंटिंग और डॉक्टर दे देते हैं। और मैं डॉक्टर साहब से मिला हूं, अभी जो रश्मि जो शायद होंगे पता नहीं एसएमएस के वो डॉक्टर है, सर्जन, मैं उनसे मिला हूं, हेड ऑफ डिपार्टमेंट है। उन्होंने भी कहा, वो कहते जो क्रिटिकल ऑपरेशन में हमें 8 घंटा लगता था, इस टेक्नोलॉजी से हम 2 घंटे में वो सक्सेसफुली कर सकते हैं। और उस जो टेक्नोलॉजी से 3D प्रिंटिंग वेदा के नाम से है। मैडम गायत्री मैडम से मैं कहूंगा, मैं अजिताभ जी जो अपने शर्मा साहब हैं प्रिंसिपल सेक्रेटरी हैं इंडस्ट्रीज के, मैं बच्चों को उनके पास लेके गया मई के महीने में और फाइल पूरा प्रोजेक्ट रिपोर्ट दिया, लेकिन उन्होंने आपके जो हैं मैनेजिंग डायरेक्टर हैं रिको के, उनको शायद फाइल भेज दी, वो सिस्टम की वजह से वहीं रह गई। मैं मिला कहा कि गई नहीं फाइल हेल्थ डिपार्टमेंट में, वो कह रहे हैं अभी हम बिजी हैं, भेज देंगे। तो मैं आपको एक नोट करवाना चाहूंगा गायत्री मैडम से, एक हम्बल रिक्वेस्ट से सिंह जी को भी, उस बच्चों की ये जो टेक्नोलॉजी है, ये न सिर्फ राजस्थान को बल्कि पूरे भारतवर्ष को विश्व में एक नई चीज दे सकते हैं। मैं इस कहना चाहूंगा। दूसरा, मैं एक उनका बच्चों का जो काम था कोविड के दौरान, वो भी कहना चाहूंगा, क्योंकि एमएनआईटी गोल्ड मेडलिस्ट है। अभी ऋषा मैडम ने भी कहा था, ऋषा मैडम ने भी, कि कोविड में और ये R&D उनकी जो कंपनी वो है 3D मास्क, आपके जो महानिदेशक हैं पुलिस के, उन्होंने अप्रिशिएट किया बुला के बच्चों को, उन्होंने इमीडिएटली फेस शील्ड फेस मास्क तो पुलिस के हर कर्मी को अवेलेबल कराया।
जी जी जी।
तो मेरा ये निवेदन है कि जो बच्चे हैं वो आज अपनी पहचान देने के लिए सिस्टम्स उनको समझे।
जी।
मैंने एक स्टॉल भी दिलवाई है 31B, लेकिन कोई
सर
भी
मेरा विनम्र
कोई
निवेदन
नहीं
रहेगा
करता।
कि हम थोड़ा अपनी बात
Sorry.
को संक्षिप्त रखेंगे, और मैडम ने नोट कर लिया है, सेक्रेटरी मैडम ने। सो आपसे निवेदन रहेगा कि बिल्कुल संक्षिप्त में कोई कमेंट आप कहें जिससे
डिपार्टमेंट
सभी
ऑफ
को मौका।
राजस्थान हमारे सीएम भजनलाल जी के निर्देशन में बहुत अच्छा काम कर रहा है, और मैं आपको ये बताना चाहता हूं कि आज हमारे यहाँ पर ऑल guests from other countries have come. We welcome them, and in Rajasthan there is hospitality in hospital sectors, so we welcome you all. हम ये कहना चाहते हैं राजस्थान में कि अगर हमें बढ़ावा देना है, जैसे हमारे स्पीकर्स ने बताया भी, कि आप इंडस्ट्री अगर इसको डिक्लेयर करते हैं तो हमें एमएसएमई का, इलेक्ट्रिकल टैरिफ का फायदा मिलता है, और इससे हम टूरिज्म के साथ मिलके मेडिकल टूरिज्म इन राजस्थान, और ऐसे ही हम इंडिया का डेवलपमेंट कर सकते हैं। सेकंड बात जो अभी हमारे डॉक्टर पुरी ने बताई, ऋषा जी ने बताई, कि हमारे पास जैसे राजस्थान में हमारे एचएम महोदय गजेंद्र सिंह जी खीमसर हैं और गायत्री राठौड़ मैडम है, कि हमारे पास सारी चीजें हैं, पीएचसी है, 3 टायर सिस्टम है, सीएचसी है, सब डिस्ट्रिक्ट हॉस्पिटल है, डिस्ट्रिक्ट हॉस्पिटल है, इसी प्रकार से सैटेलाइट हॉस्पिटल है, एज वेल एज एसएमएस टाइप के सुपर स्पेशलिस्ट हॉस्पिटल हैं। लेकिन जो सबसे इंपॉर्टेंट बात आपने बताई, क्वालिटी ट्रेनिंग एंड ट्रस्ट डेवलपमेंट, तो इसके लिए मैं आपको इंडियन मेडिकल एसोसिएशन राजस्थान की ओर से विश्वास दिलाना चाहता हूं कि हमारी हर जगह, या राजस्थान में 72 ब्रांचेस हैं, और हम हर जगह पे आपको, हर डिस्ट्रिक्ट में इसमें आपको पूरा सहयोग कर सकते हैं। एक और बात जो हमारे साथी आए होंगे, गवर्नमेंट लेवल पे एक बेहतरीन इंफ्रास्ट्रक्चर की जरूरत है हेल्थ सेक्टर में, उसके लिए हम हमारे एचएम का मैं ध्यान दिलाना चाहूंगा। और कुछ जो हमारी स्कीम चल रही है बहुत अच्छी रन कर रही हैं, लेकिन उसमें एक ही बात है, कुछ चीजें किसी के लिए रिजर्व है, किसी के लिए नहीं है। अगर हम किसी काम को कर रहे हैं तो इट शुड बी ओपन, एंड इन द स्कीम्स पैकेज शुड बी वेरी गुड, एंड दिस इज ऑल अबाउट मी। और आप सभी भी कहते हैं कि अगर जीएसटी कम हो जाएगा तो बहुत अच्छा रहेगा, और ये करने का आश्वासन दे देंगे, तो आप सबसे चाहूंगा कि इनका तालियां बजा के जोरदार स्वागत।
थैंक यू सो मच सर। आई थिंक इन द इंटरेस्ट ऑफ टाइम लेट अस कीप द लास्ट क्वेश्चन। एक अंतिम सवाल हम रखते हैं अपने गणमान्य जो हमारे मंचासीन लोग हैं उनके लिए।
सर, एंटायर मेडिकल फ्रेटर्निटी और सारे जो फार्मा इसमें बिजनेस करने वाले सभी लोग यहाँ हैं, तो मैं एक सजेशन या मेरा क्वेश्चन है कि हमारा जो फार्मास्यूटिकल जो इंडस्ट्री है पूरी एपीआई पे डिपेंड है, और वो जो एपीआई है वो केमिकल बेस्ड है, और वो भी ऑलमोस्ट हम इम्पोर्ट ही करते हैं। हमारे यहाँ मेडिसिनल प्लांट्स की एक वाइड रेंज है, और जो कि वर्ल्ड में सबसे ज्यादा भारत में पाई जाती है, बायोडाइवर्सिटी सबसे ज्यादा भारत में है। क्यों नहीं हमारी फार्मा इंडस्ट्री और इस मेडिसिनल प्लांट्स को एक्सप्लोर करती है? मैं एक छोटा सा एग्जांपल दूंगा सर, कि अगर बंदर को खांसी होती है तो पहाड़ी पे अड़ूसे के पेड़ के पास जाता है, एक पत्ता तोड़ के खाता है, 3 दिन 4 दिन तक वो पत्ते तोड़ के खाते हैं, और वो उनकी खांसी ठीक हो जाती है। इस चीज को जब बंदर समझता है, तो हम इतने बड़े बड़े साइंटिस्ट हैं, तो हम इस चीज को क्यों नहीं समझ पाते? हमारे देश में इतनी बड़ी एक वाइड रेंज ऑफ मेडिसिनल प्लांट्स है, तो क्यों नहीं हमारी पूरी फार्मास्यूटिकल इंडस्ट्री है इसमें एक्सप्लोर करती है? इसको केवल आयुर्वेद की तरफ हमने छोड़ रखा है। तो जब आयुर्वेद में जो रिसर्च के है, रिसर्च एक्सप्लोर करने के, एक्सेस करने के बहुत कम संसाधन है हमारे पास, न कोई बहुत अच्छी लेबोरेटरीज है, न कोई बहुत अच्छे इक्विपमेंट्स है, फिर न कोई बहुत अच्छी रिसर्च की हमारे पास लेबोरेटरीज नहीं है।
सर थैंक यू सो मच, थैक यू सो मच सर। हमने आपका पॉइंट समझ लिया है। आपने आयुर्वेदा और आपने हमारे जो संसाधन
last comment,
लास्ट सर,
I
लेट
know,
अस कीप इट इज द लास्ट।
Mr. Saab is waiting for, and we all waiting for his very important deliberation. I'm Dr. Vivek Gupta. We have, I work in Apollo Hospital, Delhi, but I have a small, I will be very crisp, only about 2 minutes. Honorable Health Minister, Madam Gayatri Rathore ji, please, Principal Secretary Health. We have been all working for innovation. You see, the topic which you have said is innovation. So what we are lacking in India, I worked in France. I belong to the family where my father was working with ICMR, Indian Council of Medical Research. and also in King George Medical College. I have done a lot of work with Professor Alan Crivier, who was the father of TAVI, which is transcatheter aortic valve implantation. In India, we have a lot of resources available. Unfortunately, we are still lagging in the research, not only the molecular research, but also in clinical research. And my submission as a policy level would be to Honorable Health Minister and Madam Principal Secretary that we should have a research department, especially the medical colleges, where there should be a special funding, not only funding, we should have a special team who should take carry out. We have huge resources available, now a lot of patients. Unfortunately, we are not able to publish the data, and we still follow the data from the Western countries. If we have a research department only for the research purpose, for the clinical department with the professor, HOD, for that purpose, only then we will be able to compete with the Western world, because we have data, but we are not able to publish. And unfortunately, even at Apollo Hospital, where I am working, we do not have time enough to even publish the data. We need a more working with more thought process, so that only we can show that India is, of course, not only developing, but getting developed, so that we can have our data coming from India rather than following the Western data and American data. My personal submission, this is really need of the hour. I was in London last week. I was thinking of presenting my data, but we had not enough. In the London valve meeting, we had transcatheter aortic valve. I was in Paris 2 months back. We were there. So we need at the policy level a department. You should propose to the Government of India, Honorable Health Minister, Family Welfare, that we should have separate research department in every medical colleges. Then only we can be able to compete and give more data. Thank you very much.
Thank you so much, sir. Thank you. I think that was a wonderful idea. I think that was the last question. Let's close it down. So we have a lot of time. I think we have a lot of time. Let's respect the time, as we know that in academia we say time is precious. It's money. So now this is we'll come to that, sir. Let's close this session. As we say, this is the last in the queue. Now, this is with great pleasure and honor. I invite on stage on the podium, Shri Gajendra Singh Khimsarji, who is the Honorable Minister, Medical and Health, Government of Rajasthan, an alumni of prestigious Doon School, Dehradun, bachelors from St. Stephen's, Delhi, and also the Bachelor of Business Administration from University of Western Ontario, Canada. Over to you, sir.
Honorable Principal Secretary, Medical and Health, Mrs. Gayatri Rathod, Detha ji, Professor Bardwaj, who took the arduous task of being the DJ today, Miss Nibetia, Madam Grace, Mr. Mandeep Kumar, Dr. Garg, Miss Richa, Dr. Puri, all our department senior officers, people from other countries who are visiting this hall, ladies and gentlemen, all distinguished guests. First of all, I would like to thank the dais for your invaluable comments, advice, and also some of the people, distinguished guests, who raised certain queries, had suggestions. We welcome them, and we will certainly look into your issues. Basically, this brainstorming session was very, very valuable. Life is a learning process, and for the government also, good proposals, good ideas, and this brainstorming session has been very invaluable to our department. Rising Rajasthan Summit is closing tomorrow, and by God's grace, people from all over the world, when you see the record MOUs which have been signed. I was earlier industries minister in my last term when I was minister, and this time the people I've seen, the enthusiasm I've seen, and the quantum of MOUs that's been signed in our department alone, 26,000 crore worth of MOUs have been signed, and they are yet to be signed. They are still in the pipeline. I express my gratitude to all the prospective investors who have come and had faith in our state. As it says, rising Rajasthan, it's a rising sun. Rajasthan has a lot of potential. We have a very big infrastructure, be it highways, be it solar parks, electricity, be it tourism, be it mines and minerals. Those of you who were there in the session with the Honorable Prime Minister yesterday, you must have seen in that 270-degree screen what all Rajasthan has. And we are still an unsung hero. And Rajasthan is now beginning to rise with our Prime Minister Modi ji at the helm of affairs, has transformed India over the last 10 years. So if the engine is strong and powerful, the train moves fast. And we are one of his bogies, and we are moving fast. Gayatri Madam, she did the presentation. You all learnt about the department. And when I saw the presentation, I said, Madam, most of my speech you've already stolen. So I have now taken out some dry gunpowder, and I have some points to make. Basically, actually these lights are so blinding. Like you feel like a rabbit in front of multiple searchlights. So, anyways, you see, what's happening today is the lifestyles, the adulteration in food. There is also legal adulteration, which I would say is the preservatives which are approved, the junk food the world is eating. There is no roughage. Today, maida is one of the most harmful things. And your pizzas and everything is made of all this food which is not good for you. You take, for example, a cow, the fodder it eats, because when you sow a seed of wheat, you have to, the farmer has to put for DAP and urea fertilizer with the seed. The horticulturist has to spray his fruits, otherwise fruit flies will not let the fruit go into the market and fetch any price. The vegetables which are today are there, all these chemicals which are almost everywhere, they are creating major hazards. And the lifestyles, people don't exercise, they don't play games. I was in boarding school, and believe me that 40% of our day used to go with games and activities. Today, small children are using scooties. There is no exercise, and therefore, human suffering is increasing at an alarming rate. And therefore, the medical and health field has a very large role to play and a very large responsibility to help in health suffering, illness. Today, you see, with all these computers, tablets, everything, and the rush for jobs, the zest to excel, people are all suffering from some kind of depression and some kind of mania because of the brain, and the brain can't take it. God has built our eyes to see long distance, not to be staring at mobile phones. I can tell you, none of you here can live without your mobile phone. Take away your mobile phone and you'll be half ill by the next day for 12 hours. So basically what's happening is, this department, I have been minister of many departments, but believe me, This is the toughest department I'm going through. And also the most gratifying department because you can do so much for society. Now, basically, cure, care, plus affordable cure and care. You know, we have a very big population, very large land area. So to provide, you know, people cannot expect the government to do everything. The public-private partnership is very necessary and we cannot do without that. It's a huge population. The Ayushman Bharat Yojana, which Modi ji launched, up to 5 lakh people are insured. Then our Ma Yojana, Mukhyamantri Arogya Yojana. This coupling both these and the cherry on the icing has been our Prime Minister launching the free medication scheme for people 70 years and above. That's just been launched. I think that's a great contribution to society. The Ma Yojana, which is what? It is basically a triangular game. You have the patient, you have the insurance agency, and you have the empaneled hospital. And you will be surprised that, you know, our state is known to be a model state in affordable medication to a large number of people. 88% of our population is covered under this universal health, this Yojana, Ma Yojana. 1.33 crore families. Well, 1.33, I was very bad in maths in school. I think it's 13.3 million. Am I right? 1.33 crores is what? 13.3 million. Families are benefiting from this Yojana with a coverage of up to 25 lakh rupees per family. This has been a very major contribution from our government, from our Chief Minister, by our department. There are 1,800 packages. And now we've introduced daycare also. And soon we are going to use the Ayushman portal to ensure that people from any state can come to our hospitals and get treated. And thereafter, we are also looking at our people from Rajasthan can go to any state for their treatment under this Yojana. When these barriers open, it's going to make a big difference. You see the empaneled hospitals, big hospitals, rich hospitals. Principal Secretary, we have attended, we've gone there for functions. 60 to 70% of their patients are people who are the beneficiaries of this Yojana. Diagnostic centers, small hospitals, big hospitals have mushroomed all over the state. And in the countryside, where 70% of our population resides, where private hospitals, it is not financially feasible, lucrative for them to enter that arena because A, they are poor patients, B, they are not enough. We have gone right to the grassroots level by having sub-health centers, even catering to population of only 1,000 people. And with the help of Modi ji, giving us 60% of the money, we are going to put a junior doctor. There'll be LCD screen. He'll have a tablet, mobile, Wi-Fi, and he can do teleconferencing with the villages. A lady can say, go on FaceTime or whatever and say, I've got this rash in sunlight, can take a photo or take a video. The doctor can say, if you have a little medical store there, this medicine is a common medicine, you can go and use it. That's the level we are going down to, right to the grassroots. We have 22,000 sub-centers, PHC, CHC. And what is most important is till a year back, most of these hospitals had only about 30% occupancy of doctors posted out there. Our Chief Minister, when he understood, he opened his heart and he allowed us to recruit 50,000 new recruits, out of which 18,000 have already been recruited. And hopefully by April, May, we will have no vacancies in any of our hospitals. That's a very, very major achievement. 28,000 crores has been allotted to our department by our Chief Minister. In addition to that, there are many, many schemes, whether it's repair of hospitals, new hospitals, medical colleges, where 60% we get from the center and 40% we have to shell in our own. There are many schemes also those. So 28,000 plus that, a lot of money is going into medical care. Basically, eradicating all these diseases. We have an arduous task. Like this year, it was record monsoon. You had typhus, you had diarrhea, you had malaria, you had dengue. And our department bravely made sure that there were hardly any deaths, maybe in the whole of Rajasthan, maybe 1 or 2 deaths by dengue. You saw COVID, and I think we should all be proud of our country, the way Honorable Prime Minister handled COVID. There were countries who did not have remdesivir. He had our own companies, our domestic companies produce all the drugs. And the discipline our people had during COVID. You saw what happened in America. There was not much discipline, but our people were disciplined. And the mortality was not that high because our Prime Minister went all out. He went flat out to make sure that medicines are procured and given on time. So we have a very tough job. You know, it's a job, if you like to do a job where you don't get much pats on your back, but you do for humanity, it is this department. A lot is happening. Medicity is coming up. Your Delhi-Mumbai industrial corridor, 30% runs through Rajasthan. Your NCR area, which is right near Delhi, between Delhi and here, is booming. Highways are coming. There are 9 expressways coming up. And with Medicity, there are a lot of opportunities. This is land of opportunity at the moment with this Maha Yojana also. We talk about innovation and equipment. If you go and see in some of our hospitals, the equipment we have, the linear accelerators, the machines we have, they are world class, absolutely. And then our hospital like SMS, which is our biggest hospital, it was built for Jaipur city, which had 2 lakh people. And today we have 42 lakh people. Anybody sneezes, he runs to SMS. Our doctors are still managing it somehow. It's a very, very tough job. And RUHS, which we are promoting in a big way, Medical colleges are coming up in almost all districts. Nursing colleges, we have the Ayushman tower coming up, 24 floors with chopper landing on top, state of the art, 1200 cars parking, aero bridges in SMS hospital between the buildings. Our cardiac tower is almost getting ready. So we are trying to do a lot, and we're trying to ensure that every district has a medical college. And people who want to invest in Rajasthan, medical college is an opportunity for you all. SMS, we have MRI machine, CT scan, PET scan, outsourced. Because the footfall is so high, we get a CT scan MRI for about, I think, 3,000 rupees or so, where the market price is 8,000. This is where private enterprise and the government can go hand in hand, and both can survive and both can swim together. And this is the need of the hour. Investment in the pharma sector, medical devices, universities, colleges, and for the NRI. भाई कुछ करना है तो अपने घर में करो जहां आपकी रूट्स है. आप कमाओगे भी अच्छा और भला करोगे तो अपना लोग का करोगे आप. It's a win-win situation. And one gentleman talked about 3D masks. You're talking about technology. AI has come a long way. You talked about the reserve packages. You talked about API based. Then you talked about the bandar that eats leaves and cures the cough. Please tell us the secret which leaves. Maybe we don't have to buy pills. And basically, one thing I find, whether it's private or public, the doctors are practicing. They're seeing so many patients in a day that abroad, when you see the doctors go for seminars, they research, they go for a holiday and just go on the computer and see the new technologies, new medicines. That is one thing which is lacking in our country. And of course, as you said about research, suggestions came about research. You talked about putting money into